I'm child adolescent psychiatrist working with children and adolescents. My main interest is ADHD and autism. So if you have any questions after the lecture, you are free to ask me. Also, if the lecture is unclear, you can also just interrupt me and say, because I don't know, everything will be as I tried the slides to be. Okay? Yes. So the main of my topic is to talk, of course, about ADHD and to differentiate and diagnose the disorder because we have many types or more types of ADHD. And ADHD is quite often complicated or is also, it's not just ADHD per se, but there are also other comorbidities, mental as well as physical. And then, of course, how to treat and manage ADHD. We have many different kinds of treatments, like psychoeducation, like psychosocial interventions, and of course, also pharmacotherapy. So here are some basic information about ADHD. So to say that we do have ADHD, we are talking about the different symptoms. These are inattention, hyperactivity, and impulsivity. Just to clarify, because usually we talk about ADHD, this is attention deficit hyperactivity disorder, but sometimes you will also hear the diagnosis hyperkinetic disorder. This is just the difference between two classifications. One is DSM, so this is a Diagnostic and Statistical Manual of Mental Disorders. It is used in North and South America, mostly in the USA. But this hyperkinetic disorder is an expression that is used in ICD classification. This is International Classification of Diseases, which is used in Europe. The difference between these two disorders it is a difference between them, but it's not important for you. Just that you know that there are two kinds of expressions, but mostly it means that we have ADHD. So ADHD affects approximately 3 to 5% of children, and the reason for ADHD to appear is abnormal neuropsychological functioning and also neurobiological correlates, which I will talk about later. A little bit about history. Sometimes we hear that ADHD is a new disorder. It was created in schools because children cannot obey teachers, they don't have enough concentration to work 45 minutes, like it was some kind of artificially done. But we know from stories, and this one is quite an old one, that children that were really hyperactive, that had difficulties obeying orders, that had difficulties in attention, were, let's say, from the manhood on. And this is one tale. It's a children's book, the Struwwelpeter. It's in German language, and from Heinrich Hoffmann. And it's a really funny book. If you read it, it's like there is a child who misbehaves all the time. And adults are really cross with him because he can't eat, he can't stand, he's just jumping around, running around. And in the book it said that this child has impulsive insanity and defective inhibition. So this is the first that we know book that was about, now we know ADHD. But this is scientific literature. So in Lancet is one of the main clinical literature. It's a magazine, it's a journal, and you have to have really good data to be published in Lancet. And the first article about ADHD was in 1902. And afterwards there were many articles going, the numbers were going on and on and on. The ADHD description was called minimal brain dysfunction or brain damage, because scientists were thinking what is the cause of this disorder, and they were thinking it has to be the brain disorder. Something has to be wrong with brain that child is behaving like this. Then in 1930s, hyperkinetische Erkrankung, this is in German. And then in 1960s, minimal brain dysfunction. So this this name stick quite long time with ADHD. So let's say 10 years ago, 20 years ago in Slovenia, they usually talk about minimal brain dysfunction. So in ICD-9, first hyperkinetic syndrome was mentioned, and then in 1980, they recognized that you don't have to have only hyperactivity, but that usually inattention is present as well in this disorder. And in DSM-3, now we have DSM-5 classification, but in DSM-3, first time it was said that you can also have ADHD without hyperactivity. So this is a little bit about history. What we know about ADHD is quite common, can be serious, can persist, can be quite persistent, is stigmatizing, and is very well treatable. Here are some basic, as I already told you. The core symptoms are inattention, hyperactivity, and impulsivity. The second very important reason or very important fact is that they have to be present in at least two environments. So if the child has ADHD symptoms just in school and not at home, or just at home and not at school, etc., we cannot diagnose ADHD. And also it has to lead to functional impairment. So it's not just that the child is like hyperactive, but he can cooperate in school, he's quite good in school, he has no troubles focusing when it has to focus, like some authority saying that there we cannot say it's ADHD. And also that we have subtypes, as I already mentioned. In hyperkinetic disorder, we have to have all three symptoms, but in DSM we can classify different subtypes. So it's combined with all three symptoms, and then we have just inattention disorder. Perhaps you heard about ADD, attention deficit disorder, and we can also have just hyperactivity disorder, even though I've never seen a child that has in ADHD that was without inattention or without attention problems. So we know that around 6% of children have ADHD, but only around 3% of adolescents and adults. So just 50% of cases are persistent. Around 50% of symptoms in adulthood diminishes, and we cannot diagnose ADHD anymore. And also from clinical samples we see that there are more male than female subjects that come to our clinic, even though we know that many girls have inattentive type of disorder, are not recognized in school settings because they are not disturbing the climate of the school work. They are just quiet, they are looking through the window, and then they are not as successful as they could be. And sometimes they come where they are 14, 16 years old, but not because of ADHD, but because they are suicidal, they're really depressed, they're really anxious. And when doing the diagnostic procedure, you can see that if you go back, you would find only ADHD, which was unrecognized, untreatable, and now it is really complicated and it's really complex. So here just a couple of slides. It's not for you to remember them because they're really full. It's just for you to remember how we can diagnose a child with ADHD. Because in common public opinion, very often people say, you know, this one has ADHD because he's running around, but it's not ADHD if not criteria is fulfilled. So we have two groups of symptoms. First one is inattention, and the second one is hyperactivity and impulsivity. And as you can read here, there are many of them, there are 9 groups of them, and to fulfill the criteria, you have to meet 6 of them. So there are many of them, like often fails to give close attention to details, often has trouble holding attention on tasks or play activities, often does not seem to listen when spoken to directly, often does not follow through on instructions and fails to finish schoolwork or work at workplace, often has trouble organizing tasks and activities, often avoids, dislikes or is reluctant to do tasks that require mental effort, often loses things, is often easily distracted, is often forgetful in daily activities. So this is the first group of symptoms, and the second one is hyperactivity and impulsivity. There are also 9 of them, and you have to fulfill 6 of them to get the diagnosis. So if we just read a couple of them, often fidgets with or taps hands. So this is one symptoms that is persistent in younger children. They're really fidgety, they cannot stay at peace. But when they're older, like 10, 12, then they're less hyperactive. But if you ask them, they will say, I'm hyperactive in the inside. So inside feeling of restlessness, but you cannot tell, like looking at them, because they are sitting still in a way. And then often leaves a sitting situation which when remaining seat is expected. This is especially in school. They're running around and making troubles. Often runs about or climbs in situations where it is not appropriate. Often unable to play or take part in leisure activities quietly. They're very loud. They are so distracted everywhere when they go. They really you cannot ignore them because they're so loud. And then it is often on the go, often talks excessively, often blurts out an answer before question has been completed, even before teacher asks them the question, the whole question, they just say something. Of course it's wrong because they haven't heard the whole question. Often has troubles waiting their turn. They just want to be, always the first one to answer. And the last one, they often interrupt or intrude on others. So they butt into conversation or games, which is really problematic in social skills, to say so. So they are not quite popular with their peers. So they have quite a lot of troubles also being popular or being acknowledged in the social settings. So all these symptoms have to be fulfilled to get the diagnosis. But if you are diagnosing older teens, like 17 years old or adults, you just have to fulfill 5 of these criteria. Because it is difficult to diagnose adults, especially because there are comorbidities, and you don't have so many information how they were when they were young, Because if 30-year-old man is coming to you, you cannot call his mother and say, how was he in the school? How was he in the nursery, right? So there are 5, from them not 6. So, but the symptoms have to be present before they're 12 years old. So if you're 15 and you experience symptoms suddenly, usually it's not ADHD, it's something else. And then, as we already said, several symptoms have to be present in 2 or more settings. There has to be clear evidence that the symptoms interfere or reduce the quality of social, school, or work functioning. And the symptoms are not better explained by some other disorder, like learning disability, anxiety, depression, autism, or something else. About diagnosing the adults, I already explained that to you. And also, it's really important that symptoms change during growing up. So sometimes symptoms in adulthood are different than symptoms in childhood, even though there is ADHD in both of the subjects. So here are the examples how ADHD can be seen in different years, like preschool years, or primary school years, as you can see, the attention span is getting longer, but it's not as long as you would expect from a normal, let's say, normal child. In kindergarten or in nursery, children are able usually to focus on activity for 10-20 minutes. It's not like reading or writing, but it's playing. They're not able to. They're switching different activities in a couple of minutes. They're really, they're quite dangerous to themselves because they cannot see what is coming after. They cannot see the consequences of their action. So they can climb somewhere and they're not thinking how they're going to get down as well. So they have to be supervised, they have to be controlled sometimes, much more than children without ADHD. So when they come to primary school, perhaps in the first and second year, they're much more flexible to go around, not just sit at the table, but afterwards they have to sit for 45 minutes. If they're not, they're problematic children, right? So they have really big troubles doing that. They're still, the attention span is quite short, like 10 minutes. They're really forgetful, disruptive. And in the lessons, they're more like fidgety and reckless. They have difficulties organizing themselves. They forget things, they forget homeworks. Even if they did the homework, they forget it at home and they're not bringing them to classroom and so on. So in this academic setting, they can have a lot of problems. And also as adults, they usually switch many different workplaces. They have difficulties obeying authority. They forget for meetings. They have difficulties planning meetings and so on. So what is the course of the ADHD? It could be chronic. Around 15% of ADHD is full persistence, so it's in long-term course, and there is 40 to 60% partial remission. Severe cases, so cases where there is really high rate of hyperactivity and really difficulties in attention span, usually are much more persistent. Also, the durability of symptoms is important. If we do not recognize ADHD, if we do not treat ADHD, and ADHD is persistent, then it leads to several problems. You can see here like low academic achievement, marital problem and dissatisfaction, divorce, a high rate of divorces in families when there is one like man or a woman with ADHD, difficulties dealing with offspring, lower job performance, unemployment. Many people with unrecognized, untreated ADHD are in prisons. Many have traffic accidents and also other psychiatric disorders. So what are the risk factors for ADHD to appear at all? It's a really strong genetic compound. So around 76% of the behavior we can explain with genes. And this is not just the case for a child, but if you have a child, adolescent, that has ADHD, it's a really high probability that also one of the parents, perhaps even both, have ADHD. Usually not diagnosed, because let's say 20, 30 years ago ADHD was quite seldomly diagnosed. But when you are doing the diagnostic, assessment with the child, many times you hear parents saying, I was the same, but they didn't know that it is ADHD and they didn't know how to help. Then there are perinatal factors. We know that low birth weight is really high risk factor for ADHD. We also know that mothers that do drugs, that consume alcohol, and also some other things that are higher rate of ADHD. There are neurobiological deficits, I will talk about that later, and of course family factors. So family factors are not the cause for ADHD. of course, it can be caused if parents have ADHD and all these problems arise from ADHD, but not is if a child is in, let's say, deprivation environment. It has more to do than with the outcome and also with the course of the ADHD. So just a couple of slides from neurobiology. We know that there is a dysfunction in the brain, like they knew in 1902 or whatever, but they couldn't prove it. But now we know that there is a frontal striatal dysfunction mediated by one neurotransmitter called GABA, and it is auto-modulated by catecholamines. That there is a dysregulation in neurotransmitters, especially noradrenaline and dopamine. And also we know that there is a delayed cortical maturation. So what does that mean? There is a slide there which shows that cortical thickness, you know, when brain is growing, is maturing, this cortical thickness is really important because it gives us opportunity to control our behavior. Especially frontal cortex is very important. And these slides that are done with different procedures can show that there is 3-year gap between children that do have ADHD and controlled children. So in a way, children with ADHD are 3 years more, or let's say immature, just looking at their brain structure. And there is another slide which is quite interesting because people usually think that brain has to be hyperactive for a child to be hyperactive as well, but it's quite the contrary. The brain is hypoactive, especially the region of frontal and temporal lobe. You can see here different colors. They were looking on how the brain is consuming glucose, and we know that if the glucose is consumed in lower levels, that the brain is hypoactive. So in children, in adolescents, in subjects with ADHD, brain is actually hypoactive, especially in these two domains. Okay, so how clinical assessment looks like. So the child comes with the family, and we take a lot of information, not just from a child himself or herself or parents, but also from school, because, you know, two settings are important. Then we do medical and psychiatric assessment. We assess comorbidities, and there are no additional tests that are necessary. Of course, if you want to know more about the child, we will hear the talk later from psychologists. We do also other psychological examination, but we don't have to do some kind of medical somatic evaluations. No, but in cases that there are some medical comorbidities like epilepsy or something like that, of course we have to be very careful not to forget about that. So what is the differential diagnosis? So one thing is that we must see that this is really ADHD, that we are not looking something else like high anxiety or depression or bipolar disorder or something like that. But the other way is that if we have ADHD, we can have all of these all together. So the comorbidity is more a rule than there is not a comorbidity with ADHD. There is one other slide that you can see many times. We have autism spectrum disorder with ADHD, so this is a neurodevelopmental disorder with social skills impairment, in communication. They have really difficulties adapting to different situations. They have really narrow interests. Then there are tics, mood disorders, anxiety disorders, intellectual disability, sleep disorder. Very often they have problem sleeping. And then there is a slide from substance use disorder. We know that ADHD especially non-recognized and non-treatable, if you don't treat the ADHD, it is a high risk factor for substance abuse and also for substance dependence. So it's not the other way around, because sometimes when we want to implement the drugs, parents are asking us whether the methylphenidate will cause addiction, but it's the other way around. ADHD is known risk factors for addiction. So what can also affect, as we already mentioned, the course of the ADHD, so the prognosis of the child or adolescent, especially the environment and of course family environment. So if we have parents with their own mental disorders, if we have parents who have a high conflict marriage, or there is a conflict in or recent divorce, if there is violence, if there is abuse, if there is severe bullying, of course the child will present with more symptoms and with more comorbidities. So we have to address all these problems during our assessment. And of course poverty and severe deprivation, it's also a cause for worse outcome. I find this slide very important because it says they're like scissors, you know, when they open up when you see a child. So if you see a child at the age of 6, usually there is ADHD and perhaps a little bit of behavioral problems, especially oppositional defiant disorder. But if you first see adolescents, let's say 14, 16 years of age, usually there are many problems, and sometimes you feel like you have an onion and you are pulling little layers aside, and in the inner side or in the core you will find ADHD. So this one, I think it's very important, this information. Okay, so what about treatments? We know that treatments have to be individually tailored. The goal is to reduce symptoms and to improve educational outcomes or academic achievements or working in a working environment, and also to reduce family and school-based problems. So the best evidence is for medication, especially for stimulant medication. Also behavioral treatments are effective, especially in mild and moderate cases, and psychoeducation for schools and for parents. So what are these psychosocial treatments? They're behavioral therapy, usually it's individual, sometimes it's problematic that they don't generalize it, they can learn this in this setting with therapists, but then when they go to the peer group or to school, it's sometimes difficult to generalize it also in the other environment. Then there is parent management training. It's particularly useful in small children, so in younger children with associated behavioral problems. And then there are school-based, especially psychoeducation with teachers and how to implement different strategies for a child to work more effective in the school setting. They are generally effective, but it's a smaller effect than medication. Of course, the first-line treatment, we don't jump immediately to pharmacotherapy when we diagnose a child or adolescent. So we have two groups of pharmacotherapy. The most known one are stimulant medication. You surely heard about Ritalin. It's methylphenidate. With very high effectiveness. Around 70 to 80% of children respond positively to this treatment. There are some side effects, especially nausea, sometimes insomnia. They could lose weight. Sometimes they're quite agitated. And some more serious side effects, which are not very common, like psychotic symptoms. They could worsen tics. They could raise blood pressure, so we have to be careful when implementing and when then controlling and seeing through with the therapy. And then are non-stimulant medication. In Slovenia we use just the first one. This is atomoxetine, which works more like antidepressant. It more or less has effect on attention, but not as much on hyperactivity. And then there is also clonidine, imipramine, but we don't use it here with our clinical practice. When parents are asking us how to help a child, they can, of course, read a lot of different information, a lot of different literature, and they are asking us whether some kind of diet could help symptoms of ADHD. Should they give them chocolate or not at all? Should they look TV or not, or something like that? So these are interventions without much evidence. We can tell parents that there is not evidence-based for these interventions, but of course, like physical exercise is something that's really important for a child, especially children with ADHD. They have many times low self-esteem, and we have to find some activity, some hobby where they can be really successful, so they can have this kind of knowledge about themselves. Even though I'm not doing so great at school, perhaps I'm swimming really fast, right? So here is the other slide, and this is the last one. It is just the summary of my talk about pharmacotherapy or interventions. And it's very important that you are looking not just at the age of a child. So if you have a preschooler, it's really, really seldom that you implement pharmacotherapy. And if you have mild cases as well. But if you have older children, adolescents with really high number and high, with symptoms that are really devastating, of course, then you can go further on looking for the right therapy. Thank you very much.